Greetings from downtown. My name is John Cherf. I'm an orthopedic surgeon, and as Maritza mentioned, I do a lot of knee and shoulder surgery. I don't do any spine surgery. I don't do any feet surgery. And I do IMEs on only things I do. So I do non-operative IMEs and impairment ratings on the back, but not if they've been a surgical case. So here's what we're going to do. We'll talk about the role of impairment ratings for about the next hour, which is going to be a bigger issue in Illinois, largely driven by our most recent piece of work comp legislation. So over the next hour, roughly, we'll talk about sort of the history of the AMA guides, which is the gold standard for impairment ratings, which is pretty good. The 6th edition is much better than the previous editions. Talk a little bit about understanding these impairment ratings, how they fit in the Illinois work comp system. Then I'll give you a variety of case examples in 4 buckets, which is a musculoskeletal provider we will use. That would be pain, upper extremity, lower extremity, and then spine and pelvis. We'll finish up those case examples, and then we'll talk about really some takeaways, which will sort of give some idea of how impairment ratings are going to affect you and I moving forward. So the guides, everyone, you know, it's the AMA 6th edition of the guides, and it's frequently referred to as the guides. And it is a guide, quite frankly. The genesis of this was back in 1958. In the Journal of the American Medical Association, or the precursor of the journal, there was an article that was published. It was called A Guide to the Evaluation of Permanent Impairment for the Extremities and Back. It was simply an article in a journal. And over the next 12 years, every year they published another article or guide in the Journal of American Medical Association. It was in 1971 that they took these 13 articles and put them into a book. And that was the first guide. That was the #1 first edition of the guide. Over the years, there have been multiple editions, 2nd, 3rd, through 6th. Various editions have had more significant input than others. Sort of the life cycle of a guide is, you know, roughly 5 to 7 years. Our most recent guide is 2008, so it's in its 4th year, and it probably had one of the bigger changes, the 2008 guide, which is really good because it makes it much more standardized. It makes it easier as physicians who are doing impairment ratings, and I'll talk to you about sort of what's different in this guide and what makes it good. So if we had to pick kind of 5 big deals, so to speak, in the 6th edition, it uses a much more international format, less idiosyncratic. So it uses the World Health Organization, has adopted this concept of the International Classification of Functioning Disability and Health. We'll call that ICF. It's very diagnosis-based, which is good, a little more evidence-based, a lot more objective as opposed to subjective. I think it's simpler, and there's less inter and intra error rating, meaning if John Cherf does the same impairment rating a month from now on the same person, I should come up with the same number. Or if John Cherf does an impairment rating and Dr. Primus does an impairment rating on the same individual, we should come up with a pretty close to a same number. We use percentages to give accurate, objective information, and you know, it's a much more systematic fashion, and it's important. I think you and I fret out the 10% of people who might be gaming the system, but there are a lot of injured workers that deserve a reliable, honorable impairment rating. And the guide sort of talks about, from a societal point of view, that, you know, tolerance of and care of the sick and disabled is an important part of the social fabric of a modern society. And that's really what the guides are designed to do. You and I are going to be using them in the sort of the work comp arena. This is a schematic of disease and conditions and how it affects one another. And if we look at the schematic, when we're talking about impairment ratings, there's some sort of health condition or disorder or trauma or disease. And impairment ratings are really very focused on the left side of this slide, sort of the body function and structures. It's very, very physiologic. So as we look at this continuum, we're very focused on the left-hand side. Disability would be much more on the right, meaning participating and acting and involvement in society, so to speak. The World Health Organization kind of talks about this continuum of pathology to quote-unquote handicap. So pathology is the underlying disease. Impairment, which is what we're focused on today, are sort of the physiological consequences of that. Disability is much more functional, and handicap would be the very end of this continuum and sort of the societal consequences going back to the initial pathology. It's important to understand the definition of impairment and disability. The guides has a definition, the state of Illinois has a definition, and we'll go through both of those. So, impairment is really the loss of function or loss of a physiologic ability to do something. It's loss of a body part or the ability to do something. Disability is how that interacts with society. So you could have a low impairment and a big disability, or vice versa. You could have a very big impairment with a low disability. So as an example, if I were the first chair violinist for Chicago Symphony Orchestra and I amputated my little finger at the DIP joint, you would get an impairment rating for that. It would be a relatively small number. But the disability of that, for me to perform my job, would be instrumental. Because I would have a hard time playing the violin. If you took a world-class soccer player and had an amputation of his small finger, you would have the same impairment rating, but the disability would be irrelevant. You don't use your hands when you play soccer, so to speak. So impairment really, it looks at physiologic challenge. Disability looks at how that might impact you on a day-to-day basis based on your vocation. When we talk about personal function and how sort of these injuries affect personal function, we put them into a couple buckets: mobility and self-care. And really, when we're talking about impairment, we're much more focused on activities of daily living by definition. And again, your impairment rating can be very independent of, say, the work activity you're doing. That will not show up on an impairment rating. It will not differentiate, so to speak. And the goal of impairment ratings are really, it's a balance. It's a bit of a juggling act. It's sort of balancing science and clinical judgment, so to speak. We're looking at things like precision, reliability, validity, and accuracy. And again, I think the 6th edition of the guides is really getting very close to a very mature, reliable way of doing impairment ratings. There are some generic templates. And let me also disclose that most Illinois physicians have not had a lot of experience with impairment ratings. And I would say we've not really welcomed this with big arms. There's not an enormous amount of enthusiasm by my colleagues and I to do impairment ratings. We're sort of stuck with this by legislation. Most of us have not done a lot unless you practice medicine in a different state, maybe had some experience there, or do some cross-state line impairment rating. But I would say overall, this is new to all of us. There's certainly a learning curve. That's why we're talking about it today and why we talk about it a lot. At OCS, we've gone through a credentialing program for our own physicians. We're spending a lot of time to make sure people get ramped up and up that learning curve as quickly as possible. So there's sort of a generic template. Independent of body type, there's a generic template. And what we can't really see here is this grid, so to speak, has a black or dark band across the top, and it's the class, the diagnostic class you put people into. There are essentially 5 classes, and then we put them in grades, and then we sort of manipulate that grade a little bit to come up with an impairment rating. But the template looks the same for the most part, whether it's upper extremity, lower extremity, or spine. The basic components of the template are: number 1, you have an impairment class, 0 through 4. There are 5 different classes. The low number is a very benevolent problem, and number 4 is a much more significant problem. Then there's an impairment percentage within that class. So say you're class 1, you're going to work within the range of your impairment class. And you'll move within that class, which has bookends based on clinical presentation, physical findings, clinical studies, and functional history. And this will become much more apparent as we go through some of these examples. So a lot of inputs kind of forcing you down a template to get to one number, and that number is really the final impairment rating, which will likely have some sort of economic importance. So general principles as we're calculating impairment is you come up with a diagnosis. It's a diagnosis-based, and we call that a key factor. So the first thing we do is we find out what's the diagnosis from the injury, and that sort of drives us through these tables to get to our impairment rating. That is the key factor, the diagnosis. The non-key factors, or what we also call grade modifiers, have to do with how they're functioning, and again, that's more for ADLs, activities of daily living, their physical examination, and their clinical studies. So again, we come up with a class. Within that class, we're going to have a range of an impairment rating, so it might be from 8 to 16% of the lower extremity. And then these non-key factors or grade modifiers will move us to see where we're going to truly end up. Is it going to be 8 or 16 or somewhere in between for the lower extremity, and then we would convert that to the whole person. So important considerations when we do an impairment rating, very similar to an IME, although I would say we need a little bit more objective information on our physical examination. So we take a history of the clinical presentation, we examine the patient, fastidious physical examination, review clinical studies, take a little bit more detailed functional history, and then the last input, which I put on here for the sake of completeness, is quote unquote this burden of treatment compliance. That means is the person you're evaluating compliant with the recommended treatment? Which sounds great, and I see a lot of people like, great, because we got these folks, sometimes they don't do what they're supposed to do. I can tell you that number 5 gets thrown out for musculoskeletal care, and it's really designed more for sort of endocrine conditions, maybe like diabetes or something like that. So of those 5 considerations, and the list is here complete, you and I are only going to use the first 4 as we look at musculoskeletal conditions. So let's go through these sort of 5 inputs that is important for a physician who's doing an impairment rating. One is the sort of history of clinical presentation. This can go into a class, again, 5 classes, 0 through 4, and in all these classes, the rank is no problem is 0, more severe problem at number 4. So as I'm going through the clinical clinical presentation, things I'm asking are, are these symptoms consistent with the diagnosis we're looking at? Is there maybe some magnification here? Are these symptoms intermittent or continuous? I'm trying to get an idea of does this story really add up? And then I come up with a class. On physical findings, again, on accurate physical examination, we can pick a class from 0 to 4. And again, as I'm going through my impairment rating, I'm thinking, do the physical findings really match up with the clinical story and the objective studies, et cetera? Are they appropriate for this disease or this process at this point? Meaning, if someone's 6 months after a routine meniscectomy in a healthy 40-year-old, should they really be having pain? Those are sort of the questions I'm asking myself. Objective studies are a variety of objective studies we use in musculoskeletal medicine. They're listed on the right side of this slide. Again, 5 classes we can use, 0 through 4. You want to have these studies available for review. So yesterday I was doing some impairment ratings and I didn't have all the data. So essentially my report says I need to see these MRIs and the reports before I can finish my impairment rating. So it's important to have all the documentation ready when they are getting an impairment rating. Functional assessment is, again, 5 classes, 0 through 4, largely looking at activities of daily living. And there are some tools that we can use for functional assessment. And I'll describe those a little bit more in a minute, but it's the Quick Dash for the upper extremity. It's an AAOS, American Academy of Orthopedic Surgeon, questionnaire for the lower extremity. And then we use this pain disability questionnaire for spine. And we also use the pain disability questionnaire if you're going to be using the pain parameters for evaluating impairment, and that will be more obvious when we get to that section of this presentation. Lastly, for the sake of completeness, is BOTC, burden of treatment compliance. Again, if you read in the lower box here, in musculoskeletal cases, upper extremity, lower extremity, and spine, it's really not used. It's sort of blended into the history of clinical presentation. Okay, so the fundamentals of the guides. When do you get an impairment? Well, number 1, you cannot have an impairment until the injured worker has reached maximum medical improvement. So I frequently get asked to give an impairment rating, and my response is they're not at MMI, and we can't do an impairment rating until they're at MMI. Meaning I can't predict, let's say someone's in my office and I figure, they should be at MMI in another 6 weeks. I can't sort of forecast or project what their impairment rating is going to be. The impairment rating is like a balance sheet. It is a snapshot. What's going on today? And you can only take that picture after they've reached MMI. There are a variety of tables which add up different impairments. You might have a shoulder injury and a knee injury, but the impairment rating can never be greater than 100%. If you are 100% impaired, by definition, you are dead. An impairment rating can never, and these are sort of some rules and thumb that you pull out of the book. An impairment rating can never be greater than the amputation level. So if someone creams their thumb, that impairment rating for the thumb injury, maybe it's a crush injury with some nerve, tendon damage, can never be greater than if you amputated the thumb. So you would default to the amputation value. I would say impairment ratings are not easy. So the fourth bullet point, they take, it requires some medical knowledge, skill, ability, and it's not easy. And I would say a lot of my colleagues and myself, we're gently moving into this space because we're forced to. But it's really out of our comfort zone. I mean, I've been in practice for 22 years, and the volume of impairment ratings coming through my office, it takes an enormous amount of work. We want to make sure we do a good job. We're new to this, and it really takes a good doc. And there are some docs that probably shouldn't do these. And they're like everything. There are some docs who should never do spine surgery, and I'm one of them, all right? I'm the worst spine surgeon in the world. It's not my passion, I'm not interested, and I don't do it. And there'll be some docs who are going to say, I really don't want to do impairment ratings. And it really puts you on the spot. I mean, you come up with a single number, an integer. There's no decimal point. You come up with a number, and you know what it's like in Illinois. We're going to get deposed, and we're going to get hammered on that number. And there's no wiggle room. I mean, you're putting your name on the line. So it's a little trepidation in getting into the space. Again, you cannot rate for the future. You can't project what's going to happen in the future. If there are a variety of diagnoses that you can use, you always pick the worst. You give the benefit to the injured worker. And quite frankly, when I do IMEs and impairment ratings, the starting point for me is the work comp system is designed to protect the injured worker. I mean, that's the starting point for me. So to move off that dime, I look for information that would change that opinion. So the goal is to give the injured worker the benefit of the doubt. But if there's bad things in there, then you start erasing maybe some of the information that's coming in, or not using it in your evaluation might be a better way to put it. I look for self-limiting behavior. I have patients who come to my office, and I ask my front staff to observe how they ambulate. Last week, a gentleman walks in, he's got a cane in his hand, he walks in, I'm here for my IME and impairment rating, he sits down in the waiting area, my nurse goes and gets him, and he can barely walk down the hall. Well, I ask my staff about this, and I look out the window when people leave my building to see how they're behaving, and I document it in my reports. So the self-limiting or non-physiologic behavior. And again, we round off to the whole number. So the book, which is the 6 guides, is about this thick, and I'll show some pictures that cover the book in this presentation. It's 634 pages on how to do impairments, and it's there's no fluff in there. It's tables, it's charts, it's very, very dense material. It's broken down into 17 chapters. Now, of those 17 chapters, you and I are going to be dealing with 4 chapters, and 98% is going to fall in the bottom 3. There will be an example where you might use the pain chapter, and people are kind of rolling their head, oh God, because pain is so subjective. The good news on the pain chapter is the greatest number you can come up for impairment rating using pain, the pain methodology, is 3%. And, of the 5 classes, 3 of them are 0%, one's 1%, 2 of them are 0%, one's 1%, 2 and 3. So if you're going down the pain road, you're going to get a small number. The meat and potatoes of what you and I are going to do are these last 3 chapters, chapters 15, 16, and 17, which is upper extremity, lower extremity, and pelvis and spine. The book, or the guides, breaks up extremities into 2 buckets, upper and lower, and they weigh them differently. So the upper extremity accounts for 60% of the whole person, and the lower extremity accounts for 40% of the whole person. So the biggest lower extremity, if you had a catastrophic lower extremity, you would only come up with 40% of the whole person. That's the most you could get out of that. And when we look at spine, cervical, thoracic, lumbar, and pelvis, this is how they weight these 4 anatomic areas. So the most whole person you're going to get from a cervical is 20%, yada, yada. Okay, so, these are legal, sort of discoverable forensic concepts. And I would say it's very different from the intuitive medical concept. So let me give you an example. When I'm doing an operation or I'm reading a medical journal and I'm talking about probability, I'm thinking there's a 95% chance this is going to happen. I'm going to get a good outcome 95% of the time. The legal definition of probability is it's going to happen 50% of the time. Pretty big difference. And legal possibility means there's less than 50% chance it's going to happen. When we talk about exacerbation and aggravation, exacerbation is a temporary phenomenon. It worsens maybe a pre-existing condition temporarily. Aggravation is permanent. And apportionment means how much did this injury really contribute to this problem? Unfortunately, that is not important in Illinois because our threshold for causation or apportionment is essentially 1%. So, and you and I have seen it, meaning you could have someone with a bad knee, pre-existing condition, and someone gives the opinion that it exacerbated that pre-existing arthritis. It's not uncommon for work comp to buy the total knee, and that's the law we're stuck with. I don't think that's a very good law. We tried to get that changed with this most recent piece of work comp legislation with no success. Maximum medical improvement, you have to be at MMI to do an impairment rating, and that's essentially saying, look, what you see is what you get. The chance of this changing within the next year without treatment isn't much. You're kind of at the end point. So it's interesting too. In my practice, my work comp MMIs are always a little longer than my non-work comp. And if you look at any clinical study that has two cohorts, whether it's rotator cuff, carpal tunnel, ACL reconstruction, you break them into two cohorts, work comp, non-work comp. The non-work comp outperforms the work comp in almost every metric. And I try to refer to studies in the literature to reel in the work comp population to be more consistent with the non-work comp population. So there are very good studies out there saying after a routine arthroscopy, you really need about a maximum of 4 weeks of physical therapy. So when I treat injured workers, I tell them that. So my starting point is, listen, you got a meniscal tear, the rest of your knee looks good, you're going to get a scope. My expectation is post-op you're going to be in therapy for 4 weeks, and you're going to be at MMI at about 3 months, not later than 3 months. And I try to plant that seed early on, largely because once they start talking to their friends who've had some work comp claims, these things can get bigger than life. All right, so diagnosis-based impairment. That is the genesis, or that's the foundation, rather, of the 6th edition of the guides. And we're going to put our diagnoses into 3 big buckets: upper extremity, lower extremity, spine and pelvis, and these are sort of the subcategories of those buckets. So how do you go about? So you walk into my office, I'm doing an impairment rating. So what do we do? First, I take a thorough history, and I examine you to make sure you're at MMI. Then I come up with a diagnosis for the body part. Then I pick a class. Classes are 0 through 4. There are 5 different classes. Then within that class, there are 5 grades, A, B, C, D, and E. The default is you start with grade C. And then we're going to move either up or down. We could go from C to a B to an A, or we could go from a C to a D or an E. The higher the letter or number, the larger the impairment rating. And the thing that's going to move that dial or move the needle are functional history, clinical studies, and physical examination. So I get a class, I get a grade, I'm going to get some sort of a number, and on the extremities it's going to be, this is your upper extremity impairment rating or your lower extremity, and then I'm going to convert it to a whole person. That is the process. Sounds easy. I wish it was that easy. Okay, so multivariable calculus here is the only bad math we're going to show, but in the red box, this is the formula we do to make the adjustment. So we pick a class. We default, in the table you can see below, to C. Are we going to stay at C, or are we going to move down to B or A, or are we going to move up to D or E? And the thing that moves us is this net adjustment formula. So to do the net adjustment formula, you need 4 variables. You need the diagnosis class, which we got from our table, and then you have to look at functional history, physical examination, and clinical studies to see if we're going to move. So let me show you how this works. So here would be an example. So look at the top line. My diagnostic class is 2. My GMFH, which is grade modifier functional history, is 2. My grade modifier physical examination is 1. My grade modifier clinical study is 2. And there's some tables where I can kind of gather this stuff. I plug those numbers into this net adjustment formula, and we come up with a -1. So if I have a -1, I go from my default grade of C and move it to a default grade of B. Or I move it from the default grade of C to B, and B is going to be a lesser impairment. Again, if within this class, my class might give me an impairment from, say, 8% to 16%, so this is going to be moving me maybe from 10% down to 12%. To give you an idea of kind of what the numbers look like, if you look at the hand, the thumb makes 40%, the next 2 fingers make 20%, the small and ring finger make 10%. The hand is 90% of the upper extremity, The upper extremity is 60% of the whole person. We can do the same thing in the lower extremity. The great toe is 17% of the foot. The lesser toes are 3%, et cetera, et cetera. The foot and ankle is 70% of the lower extremity. The lower extremity is 40% of the whole person. Now, when we start adding these numbers, you don't add them arithmetically. You go to a table, and they don't add up arithmetically. So you would say, okay, you'd go to a table, and you might add 9 and 18, and the table would drive you to a number of 25 as opposed to 27. It's the way it's set up. So if you have a couple of different body parts, they don't add up. They don't add up to be a bigger number. The tables push that number down a little bit. So again, in wrapping up on this section, we're using diagnoses. We come up with a class. Within that class, we move the grade around. We come up with a whole person impairment. And normal is an impairment of 0. 90% really is total dependent care, and 100% is no need for an impairment rating, you're dead. So how does the state of Illinois address all this stuff? Well, very similar definitions of impairment and disability. Impairment is sort of loss of function, very physiologic, and disability is how you interact, maybe functioning your job a little bit more functional is a good way to put that. So what's the most recent Illinois law starting in 2007? What are they saying to us? Well, they're saying you're using the 6th edition. So there are a variety of editions, and some states use the 4th edition. So I had a call last month, Dr. Cherf, we've got someone from out of state. Would you do an impairment rating using the 4th edition? Well, I might do that on a onesie or twosie, but that's not my passion because it's hard enough to figure out the 634 pages of the 6th edition. But some jurisdictions are relying on earlier editions. In the switching, like when the 7th edition comes out, I'm not going to be happy about it. I mean, I'm going to have mastered this, and I'm not going to be that psyched to go to the 7th edition. So I don't want to be too critical of states that are using the 4th edition because I'm going to probably be trying to do that in the future. Read the last box, and it's important for doing this. And we sort of banter at OCS of what we should do regarding doing an impairment rating on a patient you treat. The guide says, although treating physicians may perform impairment ratings on their patients, it is recognized that these are not independent and therefore may be subject to greater scrutiny. That comes out of the 6th edition guides. Personally, I don't think the treating physician should do impairment ratings because you will get challenged. It could be a waste of money. I think you're going to get challenged substantially through a deposition or through the commissioner. They should probably be an independent evaluation. Now, I still have people asking me to do impairment ratings on my individual patients, and I do them. And in a very simple case, it probably makes sense. And there's less cost if the treating physician does it. But I would say the more pure play is to have a third party do that. And probably not even your partner, probably not someone from your practice, probably a true third party. Again, Illinois states to do the impairment ratings, you got to be at maximum medical improvement. And here's the example of the concept of disability and impairment. So an amputation of the great toe for a ballerina is very disabling because it can't be on point. But for a laborer who's wearing a custom boot, it's not as big of a disability, yet their impairment rating would be the same. Okay, so let's go through a bunch of case examples. So I mentioned most of what we do will be in 3 chapters: upper extremity, lower extremity, spine, and pelvis. There will be very few exceptions of using the pain chapter or the pain methodology. So pain-related impairment, PRI. I'll give you one example. So when we do PRI, first, it has to be chronic pain. Chronic pain means it's been going on for 3 months or more. There's no role for acute pain. And then how do you kind of come up with this concept of what's a chronic pain syndrome? There are a variety of things that could put you in that chronic pain bucket. So let's assume we're in chronic pain. During my evaluation, I'm going to look, is their behavior appropriate? Is there symptom magnification? I need to recognize there's some cultural differences. You got these stoic Polish folks that are nothing hurts, and then you've got maybe some more Mediterranean populations that are a little more dramatic. Both acceptable, but significant cultural difference. If you use PRI, you can't use any of the other chapters. You use our pain disability questionnaire, which I'm going to show you next. And that's how you do the pain. So the pain actually is pretty easy to do. I think if you read what's in the box, and this comes out of the guides, that the stakes of deciding how and whether to include PRI is high, meaning it's all subjective, really. So the downside is the pain, using the pain chapter, it's subjective. The good news is you're not going to get a high number. So the pain-related impairment, these are the 5 equivalents of classes. You take the questionnaire. A low number means you're not impaired. A high number is you are impaired. You go up to 150, and you're going to fall into one of these 3 buckets. Well, if you're none or mild, you get no whole person impairment. If you're moderate, you get 1%, severe 2%, and extreme 3%. So worst case scenario, you believe everything, lots and lots of pain. The worst number you're going to get is a 3% whole impairment. The pain disability questionnaire has 15 questions. They're very simple questions, 10 points each, equally weighted. And an example of the first 2 questions: does the pain interfere with your normal work inside and outside the home? They're sort of very generic questions, largely driven around sort of activities of daily living, so to speak. So let's go through one example of a pain-related impairment. 43-year-old male, chronic burning leg pain 3 years after an ankle sprain. Pain with weight-bearing activities, walking, going up and down the stairs, prolonged standing. I examine the patients, normal. Clinical studies, essentially normal. The pain score is 72, and I believe this person, meaning I think this is a credible story. This patient would get a whole person impairment of 1%. So this would be an example. You really believe the individual. In this particular example, and this comes out of the guides, it's 100% subjective, but it's possible. You can have kind of chronic pain from some of these more minor musculoskeletal conditions. We're not going to use that methodology very often, and I include it for the sake of completeness. So let's go to upper extremity. We'll give a bunch of examples. So upper extremity is shoulder, elbow, wrist, and hand. That's what the cover of the guides look, 6th edition. So upper extremity impairment classes. Our classes, you have 5 classes, 0 through 4 on the left. They go from no objective findings or nothing to very severe. The range is the next table over. So range for the upper extremity. So for a moderate upper extremity, it's going to be in the range of 14 to 25%. And then we'll move by our modifiers within that sort of class number 2. And when we convert these to whole persons, our whole persons would be on the right. So a class 2 moderate, your whole person impairment is going to be somewhere between 8 and 15. We start out at C in the middle, and we move it up or down based on these non-key factors. One of the tools we use is the Quick Dash report. The Quick Dash report is essentially, it's a short questionnaire which is endorsed by a lot of people. So, the Institute of Work and Health, the American Academy of Orthopedic Surgeons, all these other subspecialty societies say, this is a pretty reliable tool. The Quick Dash has 11 questions. The raw score of this can be anywhere from 0 to 55. It's normalized to 0 to 100% scale. The 11 questions sort of ask you, how is it going when you're opening a tight or a new jar? Heavy household chores, carrying a shopping bag, and you rate this from a small number to a larger number. Small meaning no difficulty, larger number meaning more difficulty, and you come up with a Quick Dash score. Let's go through a bunch of examples for upper extremity. 45-year-old woman, assembly line worker, has trigger finger. It's treated with anti-inflammatory medication and injection, doesn't get better, has a trigger finger release. Functional assessment, really no symptoms 8 weeks post-op. Sounds like a non-work comp related problem, right? Our work comp would probably not be doing so well at 8 weeks, but they're doing fine. Physical examination, got a scar, it's well healed, good function. X-rays are normal. Diagnosis is trigger finger or stenosing tenosynovitis after surgery. So for me, the class is 0, right? There's no problem. Once you're in the 0 class, there's no need to massage it or move it up or down. It's not applicable. You get a 0 upper extremity number, and you get a 0 whole person number. The takeaway from here is just because you have surgery doesn't mean you're impaired, or doesn't mean you're going to get an impairment rating. You could have a variety of operations, and you have no impairment rating. And this would be an example of one of those. Now, most people wouldn't think that's, intuitively, you'd say that's not necessarily the case, but it is. Next example, 34-year-old woman, clerical assistant. She's got a 6-month history of pain in the wrist, treated conservatively. Functional assessment, she's independent with her ADL, she's doing fine. Her Quick Dash has a, reasonable number, 53 out of 55. It's bothering her. She's having some discomfort. On physical examination, she's got a lesion on the dorsum of her wrist. She's got a ganglion. So the X-rays and the MRIs confirm this. Her diagnosis is a ganglion cyst. So she would have a problem, but it would be a small problem. We would give her a class of 1, and then we would use our grade modifiers defaulting at grade C, move her up to an E based on, beyond the scope of what I'm going to talk about with all these examples. But this is an example of a ganglion cyst. Upper extremity impairment's 3%, whole person is 1. So someone could have a ganglion cyst. I really don't want to have surgery on it. They could get an impairment rating. But you can see it's a very small rating. Next example, 42-year-old male falls from a ladder, injures his shoulder while he's trimming trees. He's got pain with activities, takes some NSAIDs. His quick dash score is 50 out of 55, pretty high number. He's got some tenderness in his shoulder. X-rays are normal. Diagnosis is a contusion of the shoulder. So this would not be such a good example for work comp because you would expect that contusion to probably normalize. So, but they figure he's at MMI. He's going to have a low number, a class of 1. Persistent symptoms. My grade modification goes from C, we move it down 1 notch, you get a whole person of 1 for someone falling off a ladder and having a contusion of the shoulder with essentially normal studies, a small number. Next example, 56-year-old female. She's got carpal tunnel syndrome, positive EMG, and EMGs to be used in forensic medicine using the guides has to be a needle EMG. She had surgical release 2 years ago. She's at MMI. She's got some numbness with normal activities of daily living. Her quick dash is pretty low, functioning quite well. Well-healed scar, really normal nerve function, good range of motion. She had carpal tunnel syndrome. She had release. She's got some persistent symptoms. So one exception, and I'm going to give you a few exceptions, not to make this more confusing, but there are so many nuances in this book of other things you have to take into consideration. When you're talking about nerve entrapment or compression neuropathies, you use a little different methodology. In this example, I used table 1523, which is in the upper extremity chapter, which is idiosyncratic for nerve entrapment. But they got a very low grade, essentially a normal quick dash, 1%. So this is a post-op carpal tunnel with residual symptoms. We use a little different methodology than what I described before because you default to compression neuropathy, and the number on this carpal tunnel with, not an ideal outcome was 1% whole person. Next, 35-year-old man works in the assembly line, amputated his fingers, his index finger and his middle finger at the PIP joint. Has his stumps closed, they heal well. He's got no tenderness. He's got well-healed stumps. His x-rays confirmed he had an amputation. And as I mentioned before, when you're dealing with an amputation, it's an outlier. You use another idiosyncratic way. Just like nerve compression neuropathy, you kind of go in a special track. With amputation, you do the same thing. With amputation, you go to tables. You look up the amputation. It gives you values. And the amputation for this gentleman with 2-joint amputation at the PIP, index and middle finger, was a whole person of 17%. There's no ambiguity with amputations. You look at the level of the amputation, you go to the table, you do the math, you come up with a final number. There's little room for error. Another example, 44-year-old woman fell in a parking lot. She's got a full-thickness rotator cuff tear that was repaired a year post-op, and I tell all my patients rotator cuff is going to reach MMI at about a year. Having some pain, good range of motion, but discomfort with ADLs, activities of daily living. So pain with normal activities, physical examination, a little bit of weakness. It's very important to measure for atrophy when you're doing impairment ratings. So I don't always do that on my IMEs, but I do it on anyone I'm going to be doing an impairment rating because there are tables that allow us to weigh or evaluate atrophy. The MRI showed that there was a rotator cuff tear that was repaired. So an example, 44-year-old woman has a rotator cuff repair. She's at MMI. She's a year post-op. She's not doing great, but her class is low. Our grade modifier moves her from a C to a D, and our whole person impairment is 4%. So you kind of get in your mind that an injured worker with a rotator cuff repair, a year post-op that's not doing great, this is sort of a number we're going to end up with, 4%. I've simplified this dramatically. If you look at the chapter 15 for upper extremity, it's 110 pages. It is very dense. There are exceptions, a lot of things to take into consideration. I've tried to simplify it. I've shown 2 exceptions, nerve entrapment and amputation. For the most part, we use the tables as I described, getting a class and a grade and the non-key factors. So let's talk about lower extremity. So lower extremity, same thing. There are 5 classes, 0 through 4. 0's no problem, 4 severe. And as you move to the right of the slide, you can kind of get an idea of how these are going to weigh for a whole person. Lower extremity, the max you're going to get is 40% whole person. So there's a lower limb questionnaire which allows us to assess function. This questionnaire is the proprietary for the American Academy of Orthopedic Surgeons, developed by all of our key societies. So Hip and Knee Society, Sports Medicine, Trauma, Arthroscopy, etc. Kind of universally accepted. It's a pretty simple tool, but it forces me to make the injured worker answer some questions and to quantify how they're doing functionally. You're not obligated to use it, but it's a nice tool to have. So 7 questions, 5 to 7 points each. Your raw score is 0 to 44, and then that can get converted to a 0 to 100 score. And here are the questions. During the past week, how stiff was your lower limb? Are you walking on flat surfaces? Is that uncomfortable? Going up and down stairs? Lying in bed at night? You can see they're pretty elementary questions. But again, this is universally accepted within the medical community and certainly within the musculoskeletal community. Let's go through some examples of lower extremity. 25-year-old man drops a concrete block on his right foot. He's got no fracture. He's got severe pain. Declined treatment, rates his pain at 9 out of 10 a year after the injury. Functional history states he's not working because of his foot. Physical examination, he's got this antalgic gait, but it's really inconsistent. He's kind of cruising when he walks out the building. No real objective findings. X-rays are normal. So I look at the story and I say, you know what, this doesn't add up. Okay, I think there's symptom magnification here, and I rate this as class 0. So I had one of these yesterday. A very interesting case. Gentleman had a significant a traumatic injury to his shoulder, which could have caused pathology. Got 2 early EMGs, which documented brachial plexus injury. I was asked to look at this injured worker about 9 months later. No atrophy, none. Pec, biceps, forearm, no atrophy. A lot of subjective complaints. I asked to get a neurology consult at a university to do a new EMG, review the old EMGs. He said the original EMG reports were inaccurate. So this gentleman had been off work for 9 months. Essentially, I gave him a rating of 0. It was factitious. And the surgeon was very worried about it. I went through, a very reliable surgeon, went through the notes. He was really worried about this guy. He kind of tried to do the right stuff. He sent him to get an EMG, did all the right stuff, was worried about a brachial plexus injury. There was no brachial plexus injury. There was no atrophy. So again, it was a patient who was not being forthright. Unfortunately, it took 9 months, but that individual got a 0 class, which gave him a whole person impairment of 0. Another example, 38-year-old woman, she falls from a ladder and has an ankle fracture, a bimalleolar fracture. It's undisplaced. It's treated non-operatively. It heals. She says she's got, an occasional limp when she walks a few blocks. She's working full-time. Physical examination, there's some loss of motion. So range of motion is very important. It's objective. We can measure it. We can measure some atrophy. There's 1 centimeter of calf atrophy. X-rays show it's a healed fracture. It was undisplaced. So my diagnosis is bimalleolar ankle fracture, healed. Some arthrofibrosis or loss of motion, little strength and atrophy problem, gets a class 2, kind of a moderate maybe. It gets moved from grade C to B, and you end up with an impairment, whole person impairment of 8%. So, reliable, this stuff can happen. Probably put in a cast for a long period of time, not uncommon to get atrophy, not uncommon to get some stiffness. Add this up, and there was a real number, 8% whole person. Next example, 41-year-old male, twists his knee. MRI says he's got a medial meniscal tear. I got a meniscal tear and it hurts, but I don't really want to have surgery. I'm kind of getting along okay. Back to work, doing all the stuff I want to do, but I've got a meniscal tear and it's documented on an MRI. So even though they're back to work, they're doing all the stuff they want, they have known pathology, and I cannot give them a 0 number. So the guides will not allow that. So under the guides, I look up meniscal tear. I give it a very low number, a class 1. The grade goes from looking at my functional history, physical examination, and clinical studies. It goes from C to an A, and they get 1% whole person. So injured worker could be doing great, doesn't want treatment. I'm fine, doc. I just want to get back to work, man. I love my job. But if they've got pathology that deserves an impairment rating, they're going to get an impairment rating, and a meniscal tear would be an example of that. Another example, a 70-year-old man, he's got prior trauma to his knee. So this is an example of osteoarthritis, and this is not a great example for work comp because this would probably be a pre-existing condition. But to give an example of how we might rate someone with osteoarthritis. So prior trauma to the knee, he's kind of limping, he's using a cane, he's got arthrofibrosis, his range of motion is 0 to 90, it's your classic OA patient. He's got some atrophy, strength's not great, x-rays, garden variety, osteoarthritis. My diagnosis is osteoarthritis. When we look at these x-rays, we measure the joint space. That tells us what class to pick. In this case, we picked class 4, which is the highest class. Once you're in class 4, it affects how we use these grade modifiers, and you end up, once you get into class 4, you're going to get a pretty big number. So here's a gentleman, garden variety OA of the knee, 20% whole person impairment. Now, we've gone through a bunch of case examples, and this is about the biggest number we've seen, right? This is a challenge I see as a knee surgeon. A lot of people come to my office, injured workers, both patients and IMEs and impairment ratings. And, you know, they've got some OA. The old medical record says they've got some OA. They come in, they twist their knee. You know, it's a sprain or a strain. Doesn't get better. Who's buying the OA? I mean, who's paying for the total knee? And these are really tough cases to manage. I'll tell you, in my own practice, I let the injured worker know day one. I show them their x-rays. I explain, to get this x-ray of near bone on bone takes 10 years. This x-ray does not change in a day or a week or a month. It changes very slowly. You've got osteoarthritis. I mean, I sort of plant the seed of where this case is going. We have challenges with these cases in Illinois because of our very, very low hurdle for causation. A big part of my practice on the forensic side is dealing with these cases. Another example, 39-year-old male, steps in a hole, he's carrying some sheetrock or plasterboard. Here's a pop. Not an uncommon mechanism of injury. Tore his ACL, and he's got a bucket handle medial meniscal tear. He undergoes surgery. He reports severe pain and just complete loss of function of this extremity. I mean, you can't, doc, I can't work, man. Now, we know that there's a very good chance Derrick Rose will do something next year. You know, there are people playing sports, maybe not in the MBA and maybe not a running back in the NFL, but linemen in the NFL. Every D1 school's got dozens of people playing good sports with ACL reconstructed knees. So, you know, functional history as above, got a little bit of a flexion contracture, stable knee, no atrophy. So I'm kind of going down this road. I'm looking for really good objective information that might be inconsistent with the history. Clinical studies show good tunnels, good fixation. My diagnosis is status post ACL reconstruction with meniscal treatment. And this, you know, but he's got a flexion contracture. So that's the objective information I see. I put this person in a very low class, 1. Their default for the grade is C. I move it down to D, and they get a 5% whole person impairment. So, and they can go back to work. But it's a small number. Okay, so last chapter, we'll bore you with a few more case studies here. Last chapter is spine and pelvis. Spine and pelvis is different from the extremity chapters. We'll kind of go through how it's done. And when we do spine and pelvis, we pick a class. You start with a class, and the class, there are 1 of 5 options. Classes 0 through 4. 0 is no problem. 4 is a big problem. We break this down into the anatomic area: cervical, thoracic, lumbar, pelvis. And the percentages you see are for whole person impairment. So if we go to cervical spine, you know, the worst it's going to be is 30%, thoracic, and you go down to the bottom, the worst it's going to be is 22%, lumbar, 33%, and pelvis, 16%. Okay? So with spine, one of the tools we can use to look at function, so in the upper extremity we got Quick Dash, in the lower extremity we got AOS lower extremity survey. For spine, we use the pain disability questionnaire, which is what we used in the pain chapter. And again, it's not going to buy you much, but it's an objective tool that we should use on the spine. So again, the pain disability questionnaire, 15 questions, 10 points each. You know, you get up to a score of 150, but the biggest whole person number you're going to get is 3%. Let's go through some spine examples. 36-year-old male falls 3 feet off the scaffolding, hurts his neck. After 6 months, he's at MMI. He's got persistent neck pain. He's got some decreased sensation in his hand. You know, pain's pretty severe, doc, 8 out of 10. Maybe that's embellished a little bit. The pain disability questionnaire gets us a pretty big number. On physical examination, a bunch of guarding, but no real neurologic, no objective findings. Normal EMG, MRI shows sort of a mild disc. What do? We give them a very low class. Our net adjusted grade is C, and they get a 6% whole impairment. So a real injury. I guess we're believing a little bit of the decreased sensation, and we're buying a little bit of the pain disability questionnaire and a positive MRI. And the MRI level is consistent with a physical examination level, which lends a little credibility. Next example, 47-year-old female struck in the head and neck on a conveyor machine, working the assembly line, loss of motor function, taken to the ER, big compression fracture, C5, C6, undergoes a fusion, level above and level below. 1 year post-op, severe pain, some right arm weakness. PDQ, our questionnaire, is a pretty high number, 140 out of 150. Physical examination, sort of C5, C6, strength is weak. No triceps reflex, C7. Atrophy. Objective findings on physical examination. Strength is a little subjective. You can't fake reflexes. You can't fake atrophy. X-rays show it's fused with some loss of vertebral height. EMG confirms the same levels on our exam where we're finding weakness and reflex problem and atrophy. So they get a real number. I mean, it's going to be class 4, which is bad. It's the highest class, and you're going to get a significant whole person impairment of 28%. It's a bad case. So hopefully, we're going through these cases, and I'm not trying to kill you by imparity case here, death by impairment rating examples, but it's to give you an idea of, what can we expect. So, what's a carpal tunnel really going to be? What's a meniscus going to be? What's a significant cervical spine compression fracture, 4-level fusion with neurologic deficit? What's it going to be? So you just saw what's going to be. Next case, 44-year-old man, low back pain, some radiculopathies, moving a refrigerator. We see this all the time. Goes to the primary care doc, PT, anti-inflammatory medication, kind of gets better, then it recurs and keeps going on. He's got some back pain, some L1 distribution. It's working full time. Says he's got pain, pretty much pain, just a lot with normal activities. Physical examination, a little precarious movement, no significant neurologic defect. He's got a little decrease in sensation, positive straight leg raising. The MRI's got some bulging disc, which is not so uncommon. And my diagnosis is recurrent low back pain without significant objective findings. They're going to get a really low number. So, I guess I believe it. The mechanism of injury is consistent. It's possible. You give them a small class number, 1. Our grade adjustment gets them to a B, and their whole person impairment's 1%. So this is a kind of a back problem, possible disc. They're getting 1%. 46-year-old female, crush injury to the pelvis, secondary order car accident, goes to the ER. They're worried about bladder and urethra. There's no blood in the urine. Kind of pain persists for 9 months. So, what's the functional history? Distant walking, kind of tough walking on uneven ground. Pain really with just kind of normal everyday and stuff. Physical examination, tenor at the symphysis pubis with a palpable defect. X-ray shows there was a disruption of the symphysis pubis, about 3.5 centimeters. Real pathology, real trauma, diagnosis, traumatic symphysis pubis separation. It's going to get a class 2. It's going to get a 6% whole impairment. So kind of an MVA, pelvic disruption, you're ending up with 6%. All right, so we're wrapping this up in the next 2 minutes so we can eat. So expectations. 1, impairment ratings are new for most of us. They're certainly new to most of the physicians in Illinois. Like anything, there's a learning curve. There are many of my colleagues who I have great respect for and are very bright doctors who do not want to do impairment ratings and will not do impairment ratings. Some people are not going to go into this space. We need people to do them. And I can tell you, my first one wasn't as good as my 30th one. There is a learning curve. And I've talked candidly with my colleagues. I said, I'm doing these. I need to do them. We need to do them. But I'm a little timid about, defending my first, second, and third. And some guys who were mentors to me, who were senior to me, said, John, I've been doing these for a while, and I've gone back and looked at mine and said, why would anyone write that report? So there is a learning curve, is my point. They're not going to be perfect. And it's going to take a few to get under your belt. I'm doing a bunch of these. I did 4 different joints yesterday, so I'm getting a better handle on it. But I take the book home all the time. I reread chapters. I mean, this is not something you learn in a short period of time. Having said that, impairment rating report quality will improve over time. So if you get one of my early reports, I did my best. But there is a learning curve, okay? I would say be careful what you ask for. So, and the reason I say that, and what I'm encouraging my clients to do is to say, if you want an impairment rating, give me some direction on the diagnosis. So one thing you could do, the guy's got OA of his knee, and he's got maybe a new meniscal tear or a sprain and strain, you might say, if the patient is at MMI, please do an impairment rating using a diagnosis that was caused by the work-related injury on January 5th. Give me some direction. What you don't want to do is the default is you pick the worst condition, which might be advanced osteoarthritis of the knee, which we just saw get you a big number. So you might give us a little steerage in our diagnosis to pick the diagnosis that best represents the work-related injury. And then I would communicate with your sort of, forensic experts. There's going to be a lot of conversation. Sometimes I get people asking me things, and we talk about, is this really what you want? You might not need that. Let me finish up, and then I got one more slide. So again, as someone who's doing these, I'm really trying to balance science and clinical judgment. And the 6th edition is much better than the previous editions. It's not foolproof. When I talk to colleagues around the country who have been doing these for years, they say even in their hands, dealing with experts, maybe 2 impairment ratings in the same patient, they might be off 1 or 2 or 3%. But it's not 100%. But we're really narrowing the wiggle room or the gap of what impairment ratings would be. So in summary, 6th edition, AMA guides is very structured, should minimize variability. There are a variety of ways you might rate a patient. We've discussed those, maybe the pain methodology, or in the extremity, you might have a couple different diagnoses. You give the injured worker the benefit of the doubt, and you pick the worst. You pick the highest number. You have to be at MMI. We use diagnosis methodology. You might encourage us or give us some steerage on the diagnosis. And, these are just guides. It's not, if it were total cookbook, you wouldn't need 110 pages to teach me how to do an upper extremity. You wouldn't need 64 pages to teach me how to do a lower extremity, or 45 pages to teach me how to do a spine. There's a lot of idiosyncrasies and exceptions, and I've tried to simplify this, but we're working together on this, and that's the law right now. One question I have is, what's the fate of these impairment ratings? So we're going to give the number. What's that mean? And we need these to play out through the system, get through the commissioner. The commissioner is not mandated to apply a specific number to that. It's sort of take consideration. The commissioners might say, that's interesting, Dr. Cherf, I'm going to make my own decision. They're not forced to apply my impairment rating to a table to get to a number at this juncture. So, we'll see how these pan out. Thank you. Thank you very much.